Hi everyone, we're just letting everybody come in just now. Welcome. So welcome, we've got lots of people joining us, I think for 22 countries across the world, which is absolutely fantastic, and we're really delighted to kick off this Integrated Care Matters webinar series 9 with a webinar about supporting self-management. I am Grace Beaumont. I'm Programme Manager of Self-Management here at the Health and Social Care Alliance Scotland, and I'm joined today by 3 panellists. So we've got Caroline Brocklehurst, who is a member of our Self-Management Network Scotland. We've got Leo Lewis, who's the International Lead at the Bevan Commission. Unfortunately, Shan Jones, who was originally supposed to be presenting today, was unable to join us, so Leo has very kindly joined in her stead. And we've got Neil Stevens, Senior Manager of Systems Transformation in Toronto, Ontario. So before we get started, we've just got a little bit of housekeeping. Just for our panelists, please keep yourself on mute when you're not speaking. Everyone else, you won't have the option to be on mute or not. Please join in the chat, put questions in the chat box. As we're going along, we'll have a little presentation from me, and then all of our panelists will be presenting, and then afterwards there'll be a chat for everyone to ask questions. So just type things into the chat, into the Q&A when you think of them, and we'll answer them all at the end, and we'll do our absolute best to answer all of the questions. Here is our social media information. So we've got IFIC info and a few hashtags for IFIC and also Self-Management Week, because this event is the final event of Self-Management Week 2024, which is very, very exciting. So just before we move on to our panelists, you've got a quick presentation from me just to tell you a little bit about who the Health and Social Care Alliance Scotland are and what it is that we do. So as I mentioned, this event is part of Self-Management Week 2024, which we've run through the theme of journeys, and this week is about awareness raising for what self-management is and all of the wonderful work that's happening in Scotland but also internationally. The Health and Social Care Alliance is Scotland's national third sector intermediary for health and social care. So what we do is we have over 3,600 members, and we bring together all of those members. So those are individuals, third sector organisations, statutory organisations, and healthcare professionals. And we bring them together, and they're all people who share our vision of Scotland, where everyone has a strong voice and enjoys their right to live well with dignity and respect. So we work with our members and partners to ensure that lived experience and third sector expertise is listened to and acted upon by informing national policy and campaigns and putting people at the centre of designing support and services. Our aims are firstly to ensure that disabled people with long-term conditions and unpaid carers' voices, expertise and rights drive policy and sit at the heart of design, delivery and improvement of support and services. Secondly, to support transformational change that works with individual and community assets, helping people to live well, supporting human rights, self-management, co-production and independent living. And thirdly, to champion and support the third sector as a vital strategic and delivery partner and foster that cross-sector understanding and partnership. So a few of our programmes, we have lots and lots of programmes, but I just wanted to draw attention to a few that felt like the most relevant to today. Firstly, we have community links worker programs, so that makes links between individuals and community support through GP practices. So if you were to go to your GP and something was affecting your health that wasn't necessarily medical, so your GP couldn't help you with it, they might refer you to the community links worker and they would be able to put you in touch with third sector organisations, community organisations that could support you. So maybe issues with housing, with debt, things like that, that really have an impact on how your well-being is, but can't be solved by your GP. And the main aim of the Community Links Worker programme is to mitigate that impact of the social determinants of health. We've got a digital social health and care programme, and that's about supporting transformational change in health and social care by exploring digital and innovative technologies and ways of working. We have our Person-Centred Voices programme, which is led by my colleague Tommy Whitelaw, and that's working with health and social care and other sectors to really encourage that culture change in person-centred practices, all about thinking what matters to people. And we've got self-management, so this is my programme that I manage. Self-management, for those of you who are maybe a little bit less familiar with it, or I know that people sometimes define it slightly differently, so I always like to start off with the definition. It's a way of living and working that means that people with long-term conditions feel more in control of their health and well-being. So we like to say it's about putting people in the driving seat of their own health and care, and it really supports people to live their lives better on their own terms. And as part of this programme, we host the Self-Management Network Scotland. That's a network of over 900 individuals living with long-term conditions, unpaid carers, and disabled people, and as well as healthcare professionals and third sector organisations. And we just bring people together to talk about what they're doing well and really explore how we can make pockets of good practice happen right across the country. We also have the Self-Management Fund, which the Alliance has administered on behalf of the Scottish Government to support third sector and community-based organisations across Scotland to develop self-management activities. We've been running that since 2009, and we've awarded over 28 million in funds to 464 projects. So really a lot of good projects, and those are all looking at new ways of working or developing and building on things that they've already been trying. As part of the self-management programme as well, we lead on the self-management and co-production special interest group at IFIC Scotland, and the purpose of the self-management special interest group is really to facilitate that collaboration. Like I mentioned, the self-management network is doing that within Scotland, and this is looking internationally at how we can spread what's happening, what good work is happening within Scotland, and also learn from other people as well. It's to enhance our understanding and adoption of self-management within Scotland and internationally, and we work to enable people-centred integrated care in different health and care systems. And finally, I just wanted to talk a little bit more about Self-Management Week 2024. So as I mentioned, this is the final event that we've had of the week. It's been an absolutely fantastic week looking at everybody's self-management journeys, sharing that good practice and really building up our networks. We had the Self-Management Awards last night in the Scottish Parliament, which was a fantastic way to celebrate all of the people who are just doing that fantastic work across Scotland. And we had 7 amazing award winners. So I would encourage you all to have a look at our website and check out what they've been doing. So thank you. That's all from me just now. So I'm going to pass you over to our panellists. I'm just going to stop sharing my screen. So if I can introduce our first panellist, Caroline Brocklehurst. So Caroline is a member of the Self-Management Network Scotland. She was diagnosed with inflammatory bowel disease in 2009 and then a correlating spinal disease in 2019. So she'll be here today sharing her experience and perspective on self-management within her journey with long-term health conditions and how her lived and professional experiences have empowered her in her current roles of championing patient voice in health policy, research and peer support. So over to you, Caroline.
Thanks, Grace. Given that this is a spotlight on international self-management journeys, it's probably worth me saying that despite this Northern Irish accent, I've actually lived in Scotland for all of my adult life. In fact, I just recently marked 30 years of living in Scotland. There's also a couple of other things I wanted to note at the outset today. Firstly, although I find myself immersed in self-management daily, both on a personal and professional basis, I don't sit here as an expert in self-management, far from it. My life with long-term health issues is a constantly moving feast, and I'm very much a work in progress when it comes to the self-management of the challenges and opportunities that entails. In fact, without any disrespect to colleagues working within this field, I'd go so far as to say that by its very nature, there's not really any real experts in self-management, as inherently self-management requires continuous learning and is uniquely bespoke to every single individual and their own specific and shifting needs and priorities. Secondly, I'll describe some of my experiences and perspectives today, both as a patient and in my work as a patient representative, but I use the term patient really broadly. I understand that the term patient can sometimes carry its own baggage and stigmas. My most important message today is that effective self-management design and practice should always be human first and patient second. The truth is that successful self-management in health isn't really about any condition. It's about improving individuals' health and life odds to thrive in whatever ways that matter to us as humans, not condition areas. As Grace said, in 2009, I was diagnosed with Crohn's disease. Crohn's is a serious incurable intestinal autoimmune disease. It causes inflammation and erosion in any areas of the intestinal tract. Primary symptoms include abdominal bleeding and mucus, pain, diarrhea, vomiting and nausea, and it requires powerful treatments, including surgery in the majority of cases. 10 years later, and then in 2019, I was also diagnosed with the correlating incurable spinal disease of axial spondyloarthritis, or it's known as AXPA for short. It causes severe back pain, fusion and erosion in the spine. Secondary symptoms of both the diseases include clinical fatigue and mental health difficulties, as well as joint, skin, liver, eye and bone complications. My current treatment for both diseases is biologic immunosuppression injections, which compromise my immune system. Also, in 2014 to 2018, I suffered a severe period of illness with neurological, cognitive, psychiatric, and speech and language difficulties. The root cause of that particular illness wasn't fully identified, but a working diagnosis was settled upon of non-epileptic attack disorder, adverse medication reactions, and associated complex trauma conditions. I have to say that stating that collection of headline diagnoses can go nowhere near articulating the health and life impact of the journeys to diagnosis and complex treatment, the trauma, pain, fatigue, debility, A&E episodes, the burden of oppressive symptoms and complications, the multiple medication trial and errors, the side effects and treatment reactions, grueling investigations and procedures, and all of the associated aspects that come with those conditions over the years. Nor can it articulate the abject fear and insecurity over those years that have gone along with those headline diagnoses. Or can it articulate the stigma and desperation of the delays or misdiagnosis, or the prejudice, bias, and testimonial injustices encountered along the way, of which, sadly, there was plenty. Like many living with long-term conditions, my diseases don't exist in a vacuum, and all the associated complications, symptoms, and treatments have over the years severely impacted my health, my career, my finances, my relationships, my mental well-being, and of course also my family. But also vice versa, my context of being a female, a mother, a wife, a colleague, my job roles, my life stressors, my life stages, and more have all impacted my health outcomes and experiences too. Even in periods of remission, supported self-management practice has become a necessity in navigating my journey. Firstly, I want to highlight the word practice in that phrase. My self-management strategies and tools have evolved significantly. For several years, I was ill-educated in my diseases and treatments, as well as feeling stigmatized and isolated. My self-management practice flailed about, and I wasn't equipped with appropriate autonomy or access to effective tools or support to maximize my own health and life. Over recent years, however, whilst I have to say it's never perfect, my self-management practice has evolved to increase my odds of thriving, to give me reserves, education, resources, and habits when flares or complications do occur, or indeed life influences themselves conspire to threaten my health. My second important element to highlight in the phrase supported self-management practice is actually the word supported. While signposting can play a valuable part in that, the best self-management outcomes have always come where I have instead received active, warm hand support in navigating my journey. I've had great support with self-management from a huge variety of sources, including from health charities, NHS therapy-led services, government-funded initiatives, peer support activities, and more. I wonder if you could please put the first slide up. That I've tried to create the 4 pillars of my current self-management practice, just to give you an overview of that for you. The first pillar of that is around my better self-management education and self-management symptom management tools. The education comes from a variety of trusted sources, supporting my informed, meaningful shared decision-making in my own treatment, as well as better symptom management and patient-initiated follow-up pathways. I've practical tools such as home aids, FLAIR toolkits, employment reasonable adjustments, a can't waits card and a radar key for public toilets, and also fatigue management strategies adapted from my own self-referral to support sources. The second pillar is my self-management also now includes better lifestyle management strategies. I have to confess, though, this is definitely my biggest work in progress area. Self-management isn't the same as self-care, but it can include it along with self-compassion, and both really do matter. Whilst lifestyle factors like stress don't cause my diseases, my vulnerability to disease activity and the secondary symptoms of my conditions are absolutely impacted by factors such as stress and sleep management. Many of my lifestyle management techniques are adapted from the Thistle Foundation's excellent 10-week lifestyle management course for long-term health conditions that I was able to self-refer onto last year. But also, so many of my valuable secondary symptom management resources and strategies have actually been from my peer support as well. My self-management also includes digital tools and virtual spaces, and these have really opened up my accessibility, including medication monitoring apps, secondary symptom management apps, virtual consultations, virtual peer support, and education events. The third pillar that you could see there is around my self-management practice, now including disease progression and complication prevention strategies. So, for example, infection risk management strategies that's needed for my treatment, but also specialised exercise strategies that are crucial in my own particular self-management. Crohn's, axSpA, steroids, and indeed perimenopause leave me at risk of osteoporosis, but also essential in axSpA is maintaining my movement and strength to try and slow that spinal fusing and to protect my mobility. The fourth pillar that I've popped on there is that I now regularly participate in, or indeed now facilitate, peer support activities too. Peer support gives me real connections, hope, and identity with those who really just get it, and the ability to also make sense of what I'm experiencing, as well as that empowerment of real life shared learning to navigate that better. My work as a patient representative has been an empowering element of my own self-management practice, providing great opportunities to draw upon my variety of relevant prior professional experiences and dovetailing this with my other lived, learnt and practiced experiences. This has increased my own awareness of the research, education and self-management tools that are out there, but also how to actually access them. At a more macro level, I've also been proud to be involved in several policy areas such as the Women's Health Plan here in Scotland, patient advisory roles in health strategic planning and research strategies, in co-designing gold standards in treatment and care, being a patient advisor in healthcare professional training, and a patient representative in clinical guideline review, just to name a few. Living with health conditions can often feel disempowering, but partnering with other health stakeholders to co-design constructive change of the future health landscape for fellow patients gives me purpose, meaning, and empowerment. Next slide, please. I've had interesting discussions with the Alliance around the 5 ambitions for health and social care that they've drawn up. They also draw together my ambitions for self-management too, both at that micro individual level, but crucially also in the macro big picture too. The first of those ambitions is be human. There's no one size fits all when it comes to self-management. That means me understanding my own values and what makes me tick, and that needs to underpin the priorities in my self-management. But at a macro level, it means the fundamental culture shift to put good conversations valuing respect, real inclusion, and meaningful listening at the heart of health. I can track my best health outcomes to good interactions, fostering that warm hand support for me in the driving seat, but also great harm from poor conversations. I was interested to read the recent report called I Love the NHS But. It interviewed 2,000 patients on their experiences of the NHS. Staff shortages were, of course, cited as the top factor in harmful experiences, but this was closely followed by the impact of poor communication. I was lucky enough to do the Thistle Foundation's Good Conversations training for practitioners supporting patients with long-term health conditions. And I'd highly recommended sources like that to those who are interested in truly offering warm hand support to optimise self-management. The second ambition is lead courageously. At an individual level, that means truly committing to being in the driving seat, to maximise my health via self-management. In my own professional leadership and health journey, I've had great development with partners like the Alliance and the Scottish Recovery Network. At a more macro design level, it reminds me of Brené Brown's research that courage and vulnerability are interlinked. In planning self-management services, old attitudes of healthcare practitioners as gatekeeping custodians of all expertise and power must be replaced with bravery and vulnerability to offer that warm hand support tailored to put the individual truly first and the conditions and the systems second. This means me the third ambition on the list is reimagining investment. This means me recognising the needed investment and commitment of my own time and energy in my own self-management practice, but also recognising both the value and costs to me of that. But at a macro level, it means meaningful recognition, skills development, and resourcing for self-management strategies to deliver the valuable opportunities and efficiencies that it creates. There has to be a shift away from undervaluing the power and opportunity of self-management and considering it as some sort of cheap version of how things have been done before. Or indeed the damage of penalising individuals for actually exploring these possibilities, either by withdrawal of social security or clinical support. Self-management is an effective complement to, not a substitute for, other crucial support services. The fourth ambition is around share power. At an individual patient level, we must be helped to understand the power but also responsibility we have as the biggest stakeholders in our own health. We need to be supported and trusted in the driving seat. This requires powerful interactions rather than controlling interventions. Much like a good driving instructor uses effective communication in driving lessons, rather than always taking over with the dual controls. Effective power sharing translates into effective decisions, and that being with, not to, patients. But at a macro level, this means authentic patient partnership and co-design of self-management services, shifting those power dynamics. Much has been talked about the importance and value of lived experience in health. However, this is rarely matched with meaningful recognition, authority, or reward. There are three aspects in valuing lived experience: asking, listening, and action. Typically, we know that the asking box should be ticked. The listening part, however, is often hit and miss, but also the action is frequently actually missing an action. The final ambition is measure outcomes. Often what's measured gets done, but what if the measurements aren't the ones that truly matter to us as individuals, or aren't broad enough to measure all the impact? I supported Health Data Research UK on a piece of work last year on the importance of defining and understanding the right patient-reported outcomes. Measuring a patient's outcomes is not just measuring their conditions. In order to be valued, the difference self-management makes needs to be fully recognised by the patient, the practitioner, and health strategy decision makers. Next slide, please. Finally, I come back to my starting point that the essence of good self-management practices for all stakeholders should be bespoke to patients as individuals, fueled by powerful interactions, and involve continuous learning by the individual, by the supporting practitioners, and by wider health decision makers. Next slide, last slide, thanks. Thanks for listening. I'd welcome questions in the Q&A, and I've also popped my email and LinkedIn details on the slide, so do feel free to connect afterwards as well.
Fantastic. Thank you so much, Caroline. That was absolutely brilliant. I think a lot of takeaways. I was frantically scribbling notes there. But yeah, a lot of fantastic takeaways. And I think the key thing for me there was that kind of effective power sharing equals effective decisions. That is such an important part of self-management. So brilliant. Okay, so Pilar was asking, said, such an impressive lived experience. Thank you so much, Caroline. How do we explain to healthcare professionals what self-management should look like for people living with one or several conditions?
That's a really good question. And I suppose it goes back to that being there's no one size fits all. So it's all about that true listening and those really constructive, good conversations and good interactions to really listen to what matters to both me as an individual within health, but also within my life context as well. And then really trying to position that with I think that as patients, we're often in the feeling that we are disempowered or that we are secondary in that power dynamic, but actually in reality that isn't the case. And if we embrace that we actually are the biggest stakeholders in our own health, then it's mutual benefit to get that right in self-management practice. So I think when explaining to the healthcare providers or the people that are looking after us in whatever context, really explaining that it's mutually beneficial to get that process right.
Fantastic. Thank you so much, Caroline. Yeah, I think we're just going to come to Neil next, if that's okay. I can see we've got Leo back, which is absolutely fantastic. So Leo, we'll come to you after Neil. So Neil, Manager Systems Transformation from Toronto in Ontario. So he supports an innovative collaboration between North York Toronto Health Partners, so that's the Ontario Health Team, and Flemington Health Centre that's leveraging upstream chronic disease prevention to develop an integrated chronic disease prevention and management hub for hyper-local impact in the community. Gosh, that's quite a mouthful. The hub provides culturally and linguistically appropriate interventions that offer community-based, barrier-free access to primary care and support for chronic conditions like congestive heart failure, chronic obstructive pulmonary disease, that's COPD, and diabetes. So over to you, Neil. Thank you.
I'm here just getting my monitors set up. Can you hear me? Good morning. Well, first I'd like to begin by thanking Marie for helping all of us come together, and also the International Foundation for Integrated Care. And just wanted to note that, Caroline, just hearing you speak as we begin was really centering and really grounded us in the work we do. So I want to thank everyone for joining. My name is Neil Stevens, and I'm here to give you a sense of how we're developing an integrated chronic disease prevention and management hub. It is a mouthful. We'll find a way to whittle it down to make a little bit more sense. It is really based upon some of the upstream approaches in a hyperlocal framing for Toronto. And maybe that's where I'll begin with a land acknowledgement. Flemington Health Centre honours the land that we are on, which has been the site for human activity since time immemorial. It is the traditional territory of the Huron-Wendat, the Anishinaabe, and the Chippewa, the Haudenosaunee Confederacy, and most recently the Mississaugas of the Credit Rivers First Nations. These nations and this land were subject to the Dish with One Spoon Wampum Belt Covenant and agreements to peaceably share and care for the land and its resources. Other Indigenous nations and all settlers, including us, are invited into the covenant in the spirit of respect, peace, and friendship. Today, Takaranto, now known as Toronto, is under Treaty Number 13 and is home to many Indigenous nations from across Turtle Island, including the Inuit, the Métis. We are mindful of broken covenants and strive to make this right with the land and with each other. We are all treaty people. Many of us have come here as settlers, as immigrants, as newcomers in this generation or generations past. We also acknowledge that those of us who came here involuntarily, particularly as a result of the transatlantic slave trade. And so we honor and pay tribute to the ancestors of African origin and descent. And with that, I'll give you a bit of a preview of what I have planned in a really short window, and hopefully give you a keyhole view into some of the early development that's taking place. I have a question that, if there is a chat, that would love to get some insight from everyone over here as a grounding. You know, what comes to mind when you think of upstream approaches to chronic disease prevention and self-management and care? Feel free to drop a note, and I'm sure the team will be monitoring that as we go along. And just maybe as an entry into an introduction about myself, and I am part of a team that's known as an Ontario Health Team. And you might be wondering, what is an Ontario Health Team? Ontario is a province in Ontario. It's a city, is a region in Ontario. Ontario is a province in Canada. And the team is meant to be a new design in how individuals receive all their care, including primary care, hospital services, mental health and addiction services, long-term care, and home and community care from one team. So I'm here representing North York Toronto Health Partners, and this is a collective impact approach made up of 21 core partners, more than 30 alliance partners, patient and caregiver health council, a strong backbone team, a primary care association and primary care providers that is over 200 physicians that are being represented, and a population of just about 500,000. For those familiar with collective impact, the guiding principles are common agenda, a shared measurement, mutually reinforcing principles and activities, continuous communication, and backbone support. Some of the 5 conditions that we are mindful of in the work we do is a commitment to a shared purpose and improvement within the system being the key driving force, distributed leadership, shared responsibility, and organization or individual resources being marshaled together. A coordinated and collaborative action plan across the community is something else that we strive for, and driving innovation is what we do every day, like many on the call today. We have a shared commitment to diversity, inclusivity, and equity. And we are one Ontario Health team in a collection of 57 Ontario Health teams, with the goal of there being 58. On North York Toronto Health Partners is one of the 12 accelerated Ontario Health teams, and we'll be discussing some of that work in this conversation. I began all the way back in 2009 at Flemington Health Centre, and my real early focus was on community engagement and collective impact. I had the privilege of working with some really talented cohorts of clinicians and team members in developing upstream disease prevention work for equity-deserving populations. We began with the South Asian communities that was then adapted to the Latin American, Caribbean, and the Anishinaabe Indigenous populations in Toronto. I had the privilege of also leading the Population Health and Wellness Department at Flemington Health Centre. And over the course of the pandemic, I worked with some real superheroes that we call everyday local residents, who are our peer health community health ambassadors. And after being away for about a year as my family grew, I am back now in my new role. I'm supporting across North York Toronto Health Partners and Flemington Health Centre. And the goal here is to work alongside others and the community in the development of a new hub to support with self-management and chronic disease and access to primary care, and to help the system be reoriented to be more accountable to the populations we serve. So just to situate all of us of where I'm calling from and where are we and where does this work take place, this is Canada, that's us in Toronto. And if you zoomed in, this is what's locally known as the Golden Horseshoe, the Greater Toronto area. We're right there, right in the heart of Toronto. And that's the neighborhood that we support every day. Around the red dotted line that's known as locally as North York. So what do we know? We know that North York is a culturally rich area in Toronto. And I think some of the challenges that local residents navigate each day is the richness of the diversity and the rich diversity of languages, also recognizing that long-standing populations are also aging. And I think not news to anyone here is we're in a precarious state around primary care access. So there's varying access to care right now in Toronto. Locally in North York, over 70% of our local residents do not identify with English as their first language. And it has some real implications for how we think about doing our work a little differently. And language is really the heart of how we connect and engage. And I think for that, we need to address that as an equity barrier each day in the work we do. Language and culture go hand in hand, and simply translating doesn't really serve the communities around the cultural sensitivity. So we want to make sure that that is the work that we do every day as well. So we really focus our efforts around co-designing alongside the community to making sure that we address communication barriers, and then to work with one of the most phenomenal group of local residents known as the Peer Health Ambassadors, who have been the game changer for us. And many of us often shudder to think where we'd be today if they hadn't been there to guide us through the pandemic. And we cannot be in the future state without them alongside us. And what else do we know? We also recognize that elevated prevalence of chronic disease is quite a common phenomenon in our local neighborhoods. We also we also recognize that for the hubs being developed, they need to think about addressing not just one chronic condition. So we're going to be tackling congestive heart failure, COPD, and diabetes, and that's our goal. We're also looking to support some of the aging population and increasing healthcare needs, and then also recognizing that there's a variability around primary care attachment rates.
Yeah, that looks a little bit better. We've still got some kind of black blocks on your screen there, but we can see most of it. So
is this
I'm not sure what's... Yeah, that is better, actually.
Amazing. Awesome. Okay. So just a recap, I think we recognize there's an elevated prevalence of chronic disease. We have a population that needs more direct support. We also recognize that there's a variability in primary care attachment, and that we know that the underlying exacerbations around mental health as a result of the pandemic and post-pandemic is where we are. So we're hoping to develop the integrated chronic disease prevention and management hubs as a space for self-management and care and system navigation. We want to make sure that we're listening to the community and how we pull together integrated services that are supporting with coordination. And then we want to make sure that navigating across the system happens in a way that doesn't cause trauma to our populations and that they have the mental health supports that they need. We're also informed by a lot of our existing work around upstream disease prevention, and that's my next section to maybe address a little bit more, is around my work with diabetes prevention. There were some lessons that I'd like to quickly capture with you around how we're designing this, informed by these lessons. So the goal of the South Asian Diabetes Prevention Program was to enhance equitable access to upstream diabetes prevention programs and culturally relevant, language-specific self-management services in Northeast Toronto, some of that map that I showed you. The team focused on 11 distinct South Asian populations and diasporas, either not yet living with diabetes or at risk or unattached. And this has been the impact of the program over 10 years. The number of mobile early detection clinics, the mobile diabetes prevention workshops, 1,400 for local residents who were engaged to be screened one-on-one to make sure that they had a sense of their risk factors and be thought about their modifiable and non-modifiable risk factors, with the underlying risk being associated with the fact that resettlement exacerbates risk as well as other social determinants of health. Over 10 years, the teams screened 9,000 local residents. And in general, over the last 10 years, the team has engaged directly, uniquely, with about 27 local residents. And a little bit of a chuckle for everyone over here on a Thursday. We did some quick math. And for the cohort of teams that brought mobile-based, barrier-free approaches to the community on a team model that was about 3 to 4 staff, we traveled collectively 100,063 1,000 kilometers over a 10-year period, navigating quite a large area. And I think maybe thinking about some of the lessons learned, I think community-centered care is a non-negotiable for the teams we work with. And I think for equity-deserving populations, we want to make sure that we have, as Caroline said, tailored and bespoke approaches to culturally relevant and language-specific interventions. We want to make sure that there are holistic risk assessments to make sure that in the risk capturing, we assess also social determinants of health and that we have a comprehensive view of the participants' need. We want to make real-time adjustments. So not annually, but as granular as quarterly, monthly, and sometimes even bi-weekly to assess where we are. We want to leverage integrated care models for maximum impact. So the teams were able to make those areas of impact because they work really hard to think about how to leverage EMR data to help management of chronic disease. And then for the team to recognize that we need to really be vulnerable and open to the fact that we don't have all the answers, and feedback loops are really important. Striving to excellence, and we don't have all the answers, and our communities need to be the ones that guide us. And so as the teams embrace data-driven iterations, they also had a really close connection to the community to keep debriefing with them and as teams. I think notwithstanding the impact that you just saw, programs like SAPI were a little too standalone, and clients and caregivers and primary care providers were left to act as their own integration hubs. So what next is the new model around the integrated approach to chronic disease should help handle this integration work. And I'll speak a little bit about our integrated clinical pathways. Now, once again, just as a reminder, North York Toronto Health Partners is an accelerated OHT or an accelerated Ontario Health team. And we were recently mandated to develop and implement integrated clinical pathways for COPD and CHF. These pathways aim to provide coordinated and efficient care that spans across different healthcare settings for both communities and providers in North York. But rather than developing traditional linear pathways, we thought, why don't we encompass the entire patient journey? And then based on and feedback, we reframed our ICP work, integrated clinical pathway work, to focus on integrated chronic disease prevention and management. So this approach was really informed by lots of community engagement, a review of quality statements and standards, engagement with partners, feasibility and impact analysis, and that is helping us build this framework for our populations. There are 8 distinct and novel areas that we're calling our local change initiatives that range from navigation and digital to tackle CF, COPD, and diabetes. At the heart of this, the human beings that we work with and the populations we support need acknowledgement and a reorienting of our health system and interventions to directly address some of the common risk factors. And this is where the intersection of our locally driven population health approaches sharpen the focus in this work. We are focused on areas like food insecurity, lack of access to physical activity, tobacco consumption, chronic stress, and resettlement stress, but the underlying risk factors of social determinants of health and poverty, and recognizing that all of these risk factors together for the populations we serve exacerbate their risk for blood pressure, how their body's pathophysiology is impacted by these stressors, and how that leads them to have a higher risk for chronic conditions like diabetes, like cardiovascular disease, respiratory disease, and cancer. And these are the change initiatives that we are really focused on. Looks like for navigation of resources and chronic disease. So we're really focused on, before we even talk about COPD, CHF, we want to make sure that the community is on the journey with us, that we make sense of what they need support with, of how do they have those conversations with local residents in the communities, in the grocery stores, in the places of worship, at the bus stop, waiting for an elevator. How do they deconstruct that? We're also thinking about tools that are really culturally responsive and language specific, but also helpful to providers in navigating this work. And that also means we're in the process of developing this hub for chronic disease around self-management and care, and also building this on diabetes prevention models, because they have done some of the most equity-enhancing work locally in the community around chronic conditions. We recognize that the connective tissue in this work is going to be the data, so we're working really, I guess, around the clock to kind of think about what the scaffolding around data needs to look like, to be able to not have to have clients share their story across different points in the journey, so that if they share something at a hospital, someone downstream or upstream is also aware of what they need support with, because that itself can cause discomfort and doesn't feel nice. We're also working really hard on making sure that training and uptake for clinical and digital tools are in a space where providers find them helpful. We're thinking about adoption of advanced care planning, and in general want to make sure that the entire continuum of chronic disease around these 3 conditions are supported. With that, we are now in the space of thinking there's a lot to do, how do we do it, and we're focused really on thinking about what is minimally viable for us to do next. So I'm going to just give you a sense of where we are today. We're early days. As we develop a minimally viable program for chronic disease, we're really focused on thinking about what can we do with what we have to make an impact today, tomorrow, the next few weeks, as we get ready for the next calendar years that are coming up. And we imagine that the Chronic Disease Hub would help local residents, providers, and communities and caregivers engage with the hub in what you likely see on the screen. And just for a point of reference, at the bottom are some of our teams and our community health ambassadors and some of the early innovations around community health and information fairs about how we bring mobile-based work to the community. And if integrated chronic disease management and prevention as a hub is that connective tissue for all of this work across our North York region, we imagine that if someone comes to the hospital or is discharged with any of the chronic conditions, they're referred to the hub, and then the hub and staff at the hub and community ambassadors and those with lived experience at the hub are working with other partners in the system, whether they're team-based primary care models or community health ambassadors, population health teams, health promotion teams, to see how they can not just be referred, but also making sure that they're attached and enrolled, and that in that journey of attachment and enrollment, we're addressing their social determinants of health. So that could be transport and support with advocacy for housing, or support with employment accompaniment, etc. We're also thinking about our partners who are really engaged in community support services and our local grassroots groups as well, engaged in drop-in programs and caregiver programs, and how local residents who are navigating chronic conditions can help advise us on what they need for transport and meals as well. And then thinking about, as they navigate the continuum, of what kind of supports do they need in staying well in the community, or where they seek access in long-term care or supportive housing. This is early days where we imagine this constellation of supports for the hub will be evolving and maturing as we go along. There are 3 areas that we hope to support local residents with, and we hope that the hub will work collectively across North York to better support our communities across chronic disease as a continuum, from upstream prevention to getting diagnosed, to maintaining health in the community, to rapid or urgent access and end-of-life care. And we imagine that for local residents, as they think about this work and how they can be supported, we imagine that there might be someone who just recently got diagnosed and is trying to make sense of the results that they got and thinking what next, or someone who is from a family that might have a history of respiratory issues, or might be navigating either neighborhoods that have a higher prevalence of it and are worried about their risk. We want to support them with understanding what their risks are. There might be anyone in the community who comes to us and says, I know what my risks are, I've been diagnosed, but I need support with a care plan that I can co-design myself. And then there might be local residents and their caregivers and families who are struggling to make sense of how do we support those who are more advanced in the continuum. And we want to make sure that we provide wellness checks for clients, we help them with some advanced care planning upstream for them and their families, and that we increase the number of patients who receive care in the home following visits. We imagine that there might be a diversity of residents, so we've got to be ready to meet them anywhere across this continuum, and that is what we're really intensely focused on. And with that, I want to also thank all of the teams, the community, and the stakeholders working relentlessly to meet the chronic disease self-management and primary healthcare needs of those who we serve. So thank you for this opportunity to share this journey. It is beginning. I think we know where we're headed to. Check in with us shortly to see how we mature. Thank you.
Thank you, Neil. That was a really interesting presentation. It's great to see that kind of constellation model, how many different areas are feeding into it, that real sort of integrated approach to care for people. So thank you very much. Our next speaker is Leo Lewis. So Leo has kindly joined us today. She is the international lead at the Bevan Commission in Wales. She works with and alongside others to bring her knowledge, skills and experience together to co-create new transformational change approaches, including care pathways for delivering integrated care, especially those facilitated by digital solutions to meet the needs of different populations. And she has a keen interest in rural health and well-being, vulnerable populations, innovation and transformation, and is an international leader of the Bevan Commission, Wales's independent think tank, where she supports its exemplars and fellows to promote and share their initiatives internationally and learn from others across the world with the benefit of people living and working in Wales. Over to you, Leo.
Thank you very much, and it's a great privilege to be part of this exciting and informative event, and I hope that I can do justice on behalf of my exemplar colleague Sian Jones, who is works in the Red Kite Health Solutions Community Interest Company in Powys in Wales. She's had a close family bereavement last weekend and is unable to actually present her exemplar project. So I have stepped in. I've not seen her present, but she kindly provided me with a very full report on her project, which I will read extracts from and take you through her slides that she sent to me yesterday. So apologies for that, and if anybody wants to be in touch with Sian after this, I will be able to connect you together. So Sian's project was about pain. Chronic and persistent pain is a major health concern that affects about between 1/3 and 1/2 of the UK population and accounts for 22% of all primary care consultations. Patients with this condition are likely to consult their GP up to 5 times more frequently than other patients, with 41% reporting that their pain prevents them from working. These issues have been further exacerbated by increased waiting times in the UK, particularly here in Wales. With the increasing life expectancy of the UK population, it's anticipated that chronic pain will become an even greater problem for patients, their families and society. Next slide, please. This is the view of a patient at the start of Sian's project, Joe, captured in March 2023. And you'll see it very much reflects what you were saying, Caroline, at the beginning of your journey when you were first diagnosed with Crohn's disease. I think he clearly felt that the pain was taking over his life. Next slide, please. Welsh Government recognised the gravity of the problem in modern society, and in 2019 they published the Living with Persistent Pain in Wales document, and in this it emphasised the importance of early access to patient education and support for well-being in order to manage this often debilitating condition. The guidance was relaunched in 2023, and it further highlights the need for early intervention and accessible support services at the primary care level. The evidence base for appropriate interventions in this area is substantial, underpinned by the recently released guidelines. The International Classification of Diseases, in the 11th edition, classified primary chronic pain conditions as a disease state that requires appropriate management. And the NICE guidance, published in 2021, recommends chronic primary pain to be managed holistically using a biopsychosocial approach, as does the All Wales Medicine Group strategy guidance in 2022, with frequent review of medication and appropriate titration of that medication. Next slide, please. However, the ability to meet the demands of this debilitating condition is hindered by several constraints within the general practice model, including capacity issues, inconsistent knowledge, and a lack of primary care training, all factors that limit the feasibility of providing care that meets the current guidance. A previous lack of evidence to guide the day-to-day management of patients has made it difficult to target resources or identify educational needs adequately. Many patients finally presenting to their GP receive just a 10-minute appointment, allowing little time to holistically assess, enable continuity of care, or co-produce solutions. This leaves many patients receiving suboptimal care due to inconsistent knowledge of persistent pain management and a lack of dedicated services aimed at early intervention. Pressure to provide an immediate fix has seen opioid prescribing in Wales rise by 30% in the 10 years from 2008 and 9 to 2018 and 19, and I think that it's increased even more since then. Next slide, please. So what were the aims and objectives of Sian's project? The overarching aim was to introduce a pharmacy technician-led pain management service focused on improving the lives and management of any patient living with or at risk of developing persistent pain. Providing an early intervention with a biopsychosocial approach, the service would provide patients with support and appropriate care, helping to reduce their risk of developing persistent pain or improving the management of their persistent pain. This would then avoid unnecessary referrals for imaging and interventions, whilst giving patients self-management skills, structured plans to improve the quality of their lives, and reduce the burden on other services. Medication optimisation also forms part of a management plan in line with current guidance. Improvements in these areas will further reduce the waste of resources and cost to the NHS. In addition, Sian wanted to assess the clinical requirements and develop educational tools to raise awareness of this new model of care, so that it may be embedded, scaled and spread further to improve current outcomes. This work did involve bringing together and bridging the divide between related services by working closely with primary and community colleagues to refine and develop pathways, and by providing a point of expertise at the primary care level. Next slide, please. So, information on the methodology and approach taken by Sian and colleagues can be found in the full report that Marie will put in the chat for anybody that's interested in reading it. But I'm going to actually focus on the outcomes that were gained during her project. The evaluation that she used a mixed method approach to data collection and included clinical system searches, health board costs and prescribing data, and patient and clinician feedback. Overall outcomes, the education and support outcomes at a primary care level resulted in a dramatic shift in the culture of the host practice, and has resulted in a practice agreement that tramadol is no longer prescribed as a first choice medication, review of newly started patients on any opioid medication, agreement to implement opioid contracts with patients from June of this year. This forms an agreement between the GP and patient regarding the use of opioid medication and commitment to engaging with support services. A letter was sent to newly registered patients with tramadol on their medication lists regarding the practice stance and requirement for a review of their medication. Practice referral to the pain management practitioner for review and/or to manage expectations prior to onward referral to secondary care if necessary. The protocol is now used by all prescribers regarding a review of kidney function for gabapentin and pregabalin as part of the patient consultation. Next slide, please. So the impact on the prescribing and the culture, we can see from this graph on the top line that before the intervention, the prescribing spends for gabapentin were increasing, and in March 2023, the practice expenditure was £6,300. After the intervention initiation, the expenditure dropped to £3,500 in 6 months. This is a decrease of 44.5%. We can project the potential first year annual savings. Next slide, please. Sorry, Marie. We can project the potential first year savings of £9,802 on tramadol and gabapentin medications, because there were 379 active GP practices in Wales, and if we are to take a conservative view of these figures, we could think that we can get £1.7 million in savings on these two drugs alone. On the clinician time, to meet the requirements of the National Pain Guidance, a full holistic pain review requires an average of 30 minutes, with an average of 15 minutes for each follow-up appointment, which from their data collection showed that patients had, on average, 5 contacts with the service over a 12-month period. This equates to a minimum of 90 minutes per patient, including the initial review. A recent study estimates the average cost of a GP appointment to be £42, and this calculation has been based this figure has been used to calculate that within an average GP practice, there are 115 patients undergoing management of their pain. So this equates to a saving or a cost of £43,470 of clinician time that can be avoided if this model was actually implemented. In the report, there's further potential cost avoidance information available for anybody that's interested in doing a deeper dive. Next slide, please. When we look at quality of life, we can see that this was evaluated on 20 patients who had been discharged, so they did a before and after survey to look at their pain management. And despite the small number, you can see that there was an overwhelming increase in their functioning and quality of life post-intervention. Next slide, please. This here, you'll struggle to see it, but you'll get the resource coming through from Marie after the webinar. But this highlights some of the feedback from patients and clinicians that really does give a resounding endorsement to the approach that was taken by Charlotte and her colleagues. Next slide, please. And if we go back to Joe, we can see that a year later, he is in a much more positive place from his mental health perspective. They work to reduce his medication, and he's getting support through Mind. And he quotes that it's had a massive difference on his life, and he's confident that that would be the case for many others that receive this service. Next slide, please. The key conclusions were that the development of a primary care-based pain management service has had a sizable impact on the outcomes associated with persistent pain, but this poses interesting questions for the health organisations in Wales and beyond, I would argue, by demonstrating a solution to improving pain management across the population. This service has enabled the early intervention that is required to improve patient care, reduce costs, and increase capacity in primary care. Next slide, please. During the next stage, the future, we will also, Shah will be examining in more detail the educational needs that have been identified through the learning and further evidence that specialist knowledge has the potential to maximise patient outcomes across the patient care landscape. We will also concentrate on developing a care algorithm for specific painful conditions such as non-specific back pain and knee osteoarthritis, as this will help patients find the appropriate treatment for their pain quickly, improve their quality of life, and assist clinicians with local referral pathways and up-to-date information leaflets. I thought it would just be helpful just to tell you a little bit about the Bevan Exemplar programme. This is run by the Bevan Commission and is a 12-month rapid tryout and test methodology. It is run in collaboration. It's in its 9th cohort that have just started their projects, and each cohort has between 40 and 50 people from health and care in Wales, be it patients, practitioners from health, social care, third sector, or all people are invited, or industry are invited to. One of my colleagues in Wales has said that she's in cohort 9, so that's absolutely fantastic. I think I knew that, Chris, thanks. Calls usually have a thematic focus, and projects can be at a local, regional or national level. And at the end of the 12 months, the Commission organises a showcase event in the Senedd, which is Wales's Parliament, to which politicians, decision makers and exemplars and their organisational sponsors are invited. So if anybody wants to know more about the Exemplar programme, I can provide information on that, as it's a series of networking events over the 12 months where all the exemplars come together and they're supported with their redesign, their challenging current thinking and the status quo of the way that care services are delivered, evaluation, business modelling, etc., etc. Thank you.
Thank you so much, Leo. It was really interesting to all of our presenters, actually. And my kind of reflection after hearing all three of those is just the importance of education. I think all of you mentioned that education for people living with conditions, but also for healthcare practitioners. And that's how we really make sure that we have that sort of support in place for people to recognise their symptoms early, to know where to go to get support, and to be provided with the right support when they do go. So that's definitely been my takeaway from today. Everybody that's watching, you can still post questions in the Q&A section. Oh, I can see a few people have started to put them in, so that's absolutely brilliant. We've had a few questions come in, so we'll start off with those, but we'll try and get through as many as we can. We've got about 15 minutes left, and all of the PowerPoints and everything will be emailed out to you afterwards, so don't worry about that. But yeah, let's just start with the Q&A and try and get through as many as we possibly can. So first of all, we've got a question for Caroline. So thank you so much, Caroline, for truly impactful lived experience sharing. What keeps you going to advocate for such an ongoing time, and how do you keep the energy up for it?
I would say some days are better than others. I have to use all the self-management practices and strategies and tools that I have come across in doing my advocacy. And I'm thankful for actually that being part of the benefit of representing patients, is that I get to come across these things. And actually that's a huge area of development, is increasing that awareness. So many patients that I support in my peer support just have never heard of the opportunities that are out there for tools and strategies to help them self-manage in various areas. But the real thing that keeps me going, I mentioned that it can be really disempowering having gone through those experiences. So actually my roles as a patient representative or a lead patient or a patient advisor, that gives me meaning and purpose to ensure that my experiences are never in vain, and that there will always be, they'll serve to improve the experience for the people that come behind me. And the other things that keep me going is the pure need that is still there, the amount of gaps, the amount of misassumptions, and that pure need to have that patient voice in there, but also the successes. So I've truly seen in my patient advocacy and patient representation roles real successes from actually not just having my input and contribution, but having that wider co-design philosophy and meaningfully listening to the practicalities of lived experience of how that will actually progress or not the health outcomes of the patient groups that I represent. So.
Brilliant. Thank you, Caroline. Yeah, I think those successes are so important to celebrate, because sometimes it can feel like it is a lot of work that goes into every small change, but they're all so important and they just add up to a bigger system that supports people better. Thank you very much. The next couple of questions are for Neil. So Pamela was wondering, Neil, how did you address the silos within federal and provincial governments with varying political priorities? And how did you get them on board for the CDM framework? That's a big question, I would imagine, a lot of work, but yeah, how did you do it?
Big question, and I think maybe as my addendum to the slide deck that I'll share, I'll think about contextualizing these questions more thoughtfully and provide more insight. I think recognizing that we learned so much over the course of the pandemic that we had no choice but for everyone to really, per se, kind of share their cards and recognize that we are all working with limited resources in the not-for-profit sector. So really a coming together over the pandemic really gave us a glimpse of what was possible from a collective impact approach and really centering the communities in that work. So I think while structurally, historically, at least from my small vantage point, I had seen that the system was fractured and continued to fracture. But I think there'd been such a coalescing over the course of the pandemic, and I think with the development of this new model of a Ontario Health Team where everyone comes together based on the collective impact approach, it allowed us then to work together and to be more intentional about how do we place the funding that we get, to think about sustainability, to think about any pilots right from day one, how piloting can lead to sustainability. And then how do we make sure that the local residents and communities are the ones leading the conversation around advocacy, because their voices are way louder and way more valuable than ours. So, yeah.
Yeah, when you know that you have something that works and you've seen kind of proof of how people can come together, it's similar to what Caroline was saying. Actually, it kind of gives you the impetus to keep driving it forward and say, like, we've done this before, we can continue to do it. So it's fantastic. And another question for you, Neil. Somebody was just wondering: is it government funded? Is it universal for everyone, regardless of income? How does that work, funding-wise?
As far as I'm happy to be educated by my colleagues, but my sense is almost everything that we're designing, at least for now, or most of it, is at no cost to a local resident. So it may not be free. There is a cost, and thinking about really innovative ways of allocating resources is the goal here. So we sometimes pull together resources from small pots that might come federally or provincially or locally to think about what are some of the local urgent needs that we need to respond to. So that's that lens. I'm happy to add more context in the slide that I take back.
Brilliant. I'm sure people would appreciate that. And the next question is for you, Leo. I think there's two in here. So first of all, how do you consider that the programme is affecting equity of access and results? I'll let you answer that first before I answer the second one.
Okay, I'm not sure how much I can elaborate on this, but from my knowledge of kind of working in this area with a focus on chronic conditions for many, many years, I suspect that, and what's clear from Sian's report is that they had a very, very good uptake of people engaging with the service, wanting the new pharmacy technician to be looking at their medication and engaging in the education that was then provided and the supporting health management. But I also suspect that for people living with pain that were actually sitting on a waiting list for some sort of surgical procedure, for example, that those people, because they were having the better interaction with the technician and having their medication adjusted, that those people were felt better able to manage their symptoms whilst waiting for the surgical procedure. Our waiting lists are absolutely horrendous in Wales, with people waiting, up to 2 years for knee and hip replacements at the moment, depending on the urgency. So I think that this intervention is very, very meaningful for many of the people that will have embarked on it, because we all know the implications of opioid addiction. It may be an effective painkiller, but the repercussions of it are quite dramatic in many, many people. So I think it's a really good service. And then the second question around scaling it up or transferring it to other places. This is happening to some extent already. The Bevan Commission and its programme of exemplars, we have secured funding from Welsh Government to actually do the second adopt and spread of those exemplars that have demonstrated good impact. So it's likely, I suspect, that Sian's project will fall into this category, not with the current Adopt and Spread programme, because that's more aligned, I think, to some planned care work that was done, but it will certainly feature, I suspect, in future Adopt and Spread schemes.
Perfect. Thank you so much, Leo. That is all of the questions that we had in our Q&A. So I'd like to end actually by coming back to Neil's question that he posed at the start of the. Somebody's raised their hand. Can you ask a question? Did you want to say something? Yeah, well, if you do have a question, just pop it in the chat and we'd be happy to answer it. But I wanted to just end by coming back to Neil's question he posed at the start of his presentation, which was, what do you think of when you think of upstream approaches? So if we're thinking about prevention and how we get people at that very early stage, somebody in the chat box had said, which is brilliant, the person driving the discussion, which I think is absolutely fantastic. But final thoughts from all of our panelists. What does that mean to you, that early prevention, early self-management approaches? Caroline, I'll come to you first, then Neil, and then Leo. Prevention thought.
If I think about my own journey, but also the journeys of the peers that I support in peer support activities, the difference of prevention strategies it makes a tremendous difference. I mentioned that AXPA, the spinal disease, is a correlating condition to Crohn's disease, but it wasn't diagnosed for 10 years after my Crohn's disease diagnosis. Now, hindsight's a wonderful thing. I don't have a crystal ball. I don't know whether my self-management strategies that I deploy now and the education that I have now would have prevented that correlating condition developing, but I'm sure it would have resulted in earlier interventions to limit the trauma, the suffering, and the health economics of that within the system as well, of that delayed diagnosis. So I think it can't be underestimated, the importance and need of prevention strategies to tackle those experiences.
Thank you very much, Caroline. Neil, if you're on it.
I think everything that Caroline said, I'm taking a lot back in terms of notes, but I think the one thing that we're centering our work around is thinking intentionally about how do we unleash the data that we collect, in the sense that, you know, there might be designated codes for what we might not have thought about as early indicators for risk, that we can then think about a population health approach to say, you know, thinking upstream, you know, for population specific approaches of how do we identify what are the categories of risk factors that we want to be more intentional about, and that if we ever engage with the public and the populations we serve, how do we tailor risk screening tools for chronic conditions, whether it's prevention or management, and update their health records in a way that anyone in that journey is able to then say, you may not be at risk today, but I recognize that you're at risk for the future. So I think thinking about that future thinking mindset and bringing that abundance mindset to say there's still time, there's lots that we can do. Also recognizing that some of the populations that live with chronic conditions sometimes invariably or inadvertently get blamed for the chronic condition, and also recognizing how do we challenge that assumption. And then finally, to think about all the validated tools that are out there and all the validated frameworks that are out there, to bring the community to them and say, does this make sense? And what are the gaps that we are so close to that we might have a blind spot for? So if there are risk screening tools to say, is this meant to be general population? Does this serve the communities that you identify with? What can we do differently? Recognizing that for the indigenous populations, the tools may not be as responsive to their experiences and their cultures, as well as for the populations that we support around lived experiences in navigating the systems as do us LGBTQIA populations, of what do we need to do differently in reorienting the health system. So just along what Caroline said, so I think, you know, just being more mindful about better using what we have.
Thanks, Neil. That's perfect. And then finally, Leo, for your thoughts.
Yeah, thanks. I mean, I think all of our health and care systems are struggling to align people's needs with the demand that we can offer. And I think one of the ways in which this whole topic could improve over time is if we move from a single disease focus to a multi-morbidity focus, because it is rare to find somebody, as Caroline demonstrated, living with just one chronic condition. And this affects, it will make our systems much more sustainable. I suspect it will not only provide much better outcomes for patients and citizens, but actually the workforce as well, because we know that there's a lot of duplication in the system. We know that people living with chronic conditions, they struggle to participate in all the appointments that they are burdened with often. I don't think that's the wrong term to use. And the cost associated with attending those appointments as well, particularly if they are a working age. And of course, working age in all our countries is increasing. So, we need to stop really thinking about single disease and move to multimorbidity, taking things like pain, like low-level depression and anxiety as those core comorbidities that affect so many people's underlying health problems. And until we really get to that point, I think it will always be a challenge for our supported self-management services to be sustained within our health systems that claw more and more resource, funding and staff into secondary care.
Absolutely. Thank you so much, Leo. Good points raised by all. So that's us at the end of our time. I just need to leave you with the news that there is the North American Conference on Integrated Care, which is taking place in Calgary in Canada between the 15th and 17th of October. So when we share the slides, you'll be able to find out more about that if you are attending or if you're interested in attending. And also there's a call for papers open for the International Conference on Integrated Care, which is taking place next May in Lisbon in Portugal. So again, if you're interested, visit the IFIC website. All the links will be shared below. So thank you everybody for joining us today. And thank you again to all of our panelists. Goodbye.